I was a cadaver, but a living one. And we were very ambitious, and we just tried to make the point ahead of. So I have some. I will book someone to book on here alone to find out where the high identity. But now it's illegal because I didn't have the IRB approval. But no one talk about it and they don't even cite it. They publish as an abstract, and we never follow up. So they mention at the beginning, but never cited. Okay, now moving forward. I have to apologize for no reason. I must be asleep when I get the email about the title of my talk. So I prepare for plasticity, and only here when they point out, hey, Dan, you talk about limb dystonia. So I just produced my PowerPoint in the last 20 minutes. So excuse me, okay? So the PowerPoint talk only a little bit, and then you can ask me, and half of the story I tell you would be wrong, okay? For dystonia is characterized by dystonic posture, and often aggravated by purposeful action and may be specific for a particular task. May have dystonia when using the hand for writing, but not for others. You know why? Evolution, until 100 years ago, only the elite, the noble, can write, not a regular man. So that writing is not part of the evolution, and just 100 years not enough for the brain to develop. So we actually overuse it. So you see that a lot in the secretary, people who use the handwriting excessively. And then we end up having the occupational dystonia that people, again, they seem like a musician. And you will notice it also when you age, then begin to try to learn something. For example, I try after to play piano again now, and I find out that my hand is not like the way it is, and then you suddenly have a funny thing, difficult for you to train your hand to do automatically. You have to think about it to do it. So, especially for things that require repetitive movement, that when you see. And the interaction from many systems in the brain that create into when the abnormal in the equilibrium, we end up have we end up having dystonia. And I try to sell my book, okay? So that's it for my book, and the book is translated by Dr. Tai and Dr. Lê Min to Vietnamese, so you can save it, and if you want the English one, the new edition coming out within the next month, the third edition, the book have translated to 7 languages now. So so in limb dystonia, you will see the pianist, the horn player, the clarinet, the guitarist. She is a patient for me for the last 30 years and continue now that allow her to go back to play at the symphony orchestra. What happened is, you see here the hand position, they have to be able to hold the flute like that so they can move. Her hand, instead of, it is that it extended here so that she cannot breathe it well. So after the injection, she was able to hold the hand in the correct way so that she can play the clarinet again in the last 30 years. So you are also in the typist, the hand will have the hand to jump to this moment, and because they hit the return key. So you see in the dentist, in the seamstress, the watchmaker, because it's very fine movement they have to do. Now, we already mentioned that, so we don't read it again, but here you see it. Well, here the dilution, and I think that I can pass it because all the other have COVID, but that's the way I use. I'm a little bit different in the use for the D-spot. D-spot is the paper with dilution to 2 cc in the 500 unit. I was fighting again when the proposal, and because my argument is, I know that I work with a lot of smart people, but I'm not so smart. And if you dilute in 2.5 unit, 500 unit in 2.5 cc, I know exactly when I calculate and from the syringe. But if you do in 2 cc and I have to convert from Botox A to this part, I don't know how to do it. So actually, to this advantage of these sport people that I didn't switch a lot of patients because the reason I cannot sit in front of the patient and use the pen at my age. By the way, I saved my age because my age is a lot more than what I see in my face. So we have the different botulinum toxin, and actually, I didn't find much of the difference between them, even with all the advertisement. I think our skill is more than the small difference that the toxin can give. And if the toxin works longer, but if you do the whole muscle, it doesn't count. So, well, we can move to the next one. Okay, that's the recommended dose that put in the book, and you will not remember it anyway, and I not either, so just keep it. Well, here, now, in the hand dystonia, we have a few patterns. The most simple one is the focal flexor pattern, when they have a flexing of the finger. That's the easier to treat, and that's the one I prefer. You would inject in the flexor pollicis longus, okay, and that in the stone third up here, and they give it, and it's quite simple. Then the flexor pollicis brevis at here, that's the muscle you try to avoid if it's your mother. Okay? If you want to treat your mother-in-law, fine with me. Why you laugh? Okay? So, because it's quite painful, and especially put that and then try to ask the movement. So you guys go to the longus first before you try this muscle. And patients scream so much that you are not have much time to localize the muscle anyway. And we mentioned that already, so I would leave it to skip it, the picture. Well, now we go to the generalized pattern. The generalized pattern, you can see it here. Generalized flexor, flex at the wrist and flex at the finger, then here and this one here. Very common, they have increased activation of the finger flexor to the muscle with quoted in. I don't know of most of your experience, but some of the patients, especially it would be called painful to inject this muscle with activity. You don't need to inject all of them. You should inject one or two that enough to make their life easier, because they know how to get around it anyway. And if I inject all the muscle that I found involved in the handwriting, I'm losing my patient faster than I can count. And most of my patients who stay with me for 20, 30 years, because I choose only one or two, okay, to treat them. And some of them unhappy, go to the next one, and they come back after the other cause so much pain. Okay, here you see the finger, and here it's quoting at the wrist. Now, here the injection of the flexor digitotum profundus, and with the patient, the hand supine and the elbow flexed, the needle in the middle of the forearm passing to the flexor carpi ulnaris. So you choose the flexor carpi ulnaris, you go through it, you more going to in the upper part of going to the flexor digitotum profundus, and then above it, the flexor digitotum superficialis. The palmaris longus is the most superficial one, and this is barely under the skin. In some circumstances, you will inject that, but mostly you don't need that. You don't need that. Okay, finish picture. Then the flexor carpi radialis, by pulling the hand, putting it there at the radial part, you can feel the tendon of the muscle and go upward to the belly of that and inject into the flexor carpi radialis. Because the muscle is small, you try to inject at the proximal part so that you hit the belly. And the ulnaris is quite easily. The ulnaris, flexing the muscle, pull this way, the tendon, the belly coming out very easily to inject, to find. Now, the pronator quadratus, you have a patient pronate, you inject here, okay? And that it can come in easily. You can go also from the dorsal part, but it will be more painful. Then the ulnaris, the pronator teres, when you flex here, you will, that's a big muscle, so mostly you never can miss. It's about 2 finger wide. Here is the focal extensor, that raise this one finger. They raise this one finger, so you can feel this muscle quite easily. It's coming up. Normally, the patient can live with it, so you leave it there unless they move the middle finger. This the generalized extensor pattern. You see the width extend, but the finger inflexed. And this one is tough one. Why? In evolution, only human has the capacity to extend. Animal only flex it. This flexing we heard belong to the animal kingdom. Only due to evolution, human, the first one who can do this and this. That's why when the dog see you look there, they get scared. So you call the dog by doing this, because that's the way they get attacked. So this the fifth position, the proximal arm dystonia, when the shoulder muscle get pulled up and the hand like that. So here you see a lot of patients who also have cervical dystonia. Well, but by this slide, I would leave this slide there, and I don't have much later on, because later on is describe of different muscle that was used for persistence. But I would be available for you to ask questions. And thank you for listening to me.
Thank you, Dr. Truong. Any question for our guest speaker? Dr. Truong is a very well-known neurologist in Vietnam, because he has introduced the movement disorder specialty in our country. I think in the year 2003, right? Or 2000, yes, at the start of the year 2000. Please, Dr. Rosales.
Controversial statements from other people and experts. They believe that in limb dystonia, especially in writer's cramp, you need instrument guidance in injection. What is your comment on that?
Say it again.
Many experts, many I think, believe that when you inject the writer's cramp, you need instrument guidance when injecting these muscles. What is
Yeah,
your take
yeah.
about?
Well, the one who have the instrument, that's why I show it. I only have her come in with the instrument, playing it for me and identify the muscle from there. And to be honest with you, I have the EMG, I have the ultrasound machine, but slowly I believe the ultrasound machine for me will give me only the parking light. I don't have the time to use it yet, and the ultrasound doesn't help in whiter cramp because unlike a cervical dystonia, the muscle get dystonia, get big. Here the muscle is like a regular size, and so the most of the time you, especially for the one who play the flute, she play in the symphony orchestra, so the speed like very important. So you try to give you this very small amount because you try to work it around a little bit so they can function.
That said, you really recommend for limb dystonias like writer's cramp, musician's cramp, you really recommend small doses.
Very small.
One, and second, low dilution.
Yes.
Very low dilution. Okay, thank you. Two important points.
But
Any
at,
question?
but at the end, very often, okay, you are the one who gain the experience by yourself, okay, and you get used to it, what you want to do, and it depends on the circumstance very often. But inject a large volume in a muscle, especially in small muscle, they are no friend of you afterward. Thank you. Please.
And so you mentioned about the proximal arm dystonia while writing, right? So how to decide whether this is a cause of the overflow from the distal hand or this is a primarily proximal arm dystonia?
Well, very often you try to minimize the injection, limit it so much so it's not a disruption. And I would do on the patient, I inject a lot, okay? They don't like it. Most of the patients who stay with me for a long, long time, when the patient, I treat only the minimum, so they can tolerate it because they adapt with it. They only have it. And if you treat a lot, there is something with the expense, okay? Second, that's hurt more. Think about injecting on the hand muscle. That's why I keep making the joke about the mother-in-law. So, and that's my bottom line. Any other?
Thank you so much, Professor Truong, for your lectures. And actually, my question is not regarding to the limb muscles, but for the toxin injections for the other muscle, especially for the face muscle. So I would like to ask your expertise and also with the expertise of Professor Rosales.
Okay.
How is your think about or recommend for injections of bone toxins in case that is quite big controversial? For example, for patients with the blepharospasm, usually we inject the bone toxins to treat blepharospasm.
Okay.
But for people with the apraxia of eye opening, what is your decisions about the injections of bone toxins to these patients? And also for the hemifacial spasm, we usually inject bone toxin injections also. But for patients with facial synkinesia, how do you think about that? Thank you.
Well, I would try to use. Are you okay with me if I jump away from this topic and talk something more interesting? Want it? Okay. Because you mentioned about the face, botulinum toxin have a lot more application and more extensive, and I love it for different. I can do a facelift for you without cutting anything at all. Who like it? Who want it? Get a facelift without I cut anything. I change your face in one day. You look 10 years younger. Can you get the internet on here for me? Get internet on here. You look at the. You do it, and I get. Now, I love it because this one is more interesting. In my next book, we describe, but because I'm a neurologist, they try to be clean as a neurologist, so I give it to someone else to do it, but that's my law. Look, anyone have seen the face of Mr. Putin? You do, right? He looked now square-faced. You look at the picture from him 20 years ago, 1995. His face is oval. Check it your cell phone. Putin photo 1995. Putin photo 2022. I wait. Look at it. Check on it. That's more interesting. And give me an A afterward, okay? On evaluation. So Putin face in 2022. Okay? You see it? Now, look at the same put in 1995. His face is oval. See it? Video. Now, you know why? The elderly lady, when they old, they have the platysma band. That here, you see, mine begin to have it. Don't call me old though. I'm single now. Okay? And then they have this platysma band that go insert in here and go down. So that now, if you inject the platysma here a little bit, here a little bit, here, and then ask the patient to plenty of. This one is not in the book, okay? This one only to me. So, no, really, the trick I hear from you now is, that's the party trick. I go to party, talk about, the lady get around me. Okay, so you inject into this muscle at the band, so this will slow down. Okay, now the upper face muscle here will become stronger, right? Up, face lift, right? Okay, so now you can make Putin a younger man. Okay, this way. The other one is, can you put in the internet? Okay, Putin 1922 first. No, 2022. Okay, now put this picture on. Yeah. You see that? His face is square, right? Okay, now get the one 1995. Oval. See it? Bone doesn't change. So the platysma, the one who do it. Now, pull in for me platysma. Platysma, P-L-A-T-Y-S-M-A. Okay, put in. Okay, put in this. Get this. So what do you see here? You see that the plasma is a huge muscle. The whole night. And where did it point? It pull. and pull at the mouth corner and here. The one that pull here and here make your face square. And because they pull here, the lady has a line here. Okay? And because it pull at the corner here, that make the lady. Okay? So, if you give a few drops here, 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 and especially here. Okay. Now, you see what I want to show? The one that pull here, see that? It makes square. See that? And the one that pull here, her face becomes square. That's why Putin's face becomes square. And because it pull here, that's why she have the line here. Right? Okay? Because it come here, she has a double chin. Okay? Make her face not young anymore. So, if you use it together about 20 a few units of Botox, okay, and when Ibsen pay me a lot, enough, I tell you how much to give. I'm kidding. Okay? But if you do that here, you take all the line away, and the lady mouth not like that anymore. She look happy. Okay? You love it? I'm serious. Try it. Don't forget to me the credit. Okay, that's it. What?
Blepharospasm and apraxia of eyelid opening.
Okay, what do you want to ask about blepharospasm?
Actually, my question is not the same as your sessions for the limb dystonia, but I would like to ask you about the controversial in practice for the injection, because sometimes even though we use Botulinum injections for treating for the blepharospasms, but we quite very concerned for using for the injection for the indications of eyelid opening apraxia. So what do you think about how to using the Botulinum injections for these indications?
For eye-opening apraxia?
Yes.
Well,
and also
I know what you want about. The result is small, very tiny. The achievement is small, very tiny. But look at this way. The blink of an eye enough for the patient to fall half a mile. Okay, the blink of an eye, that's enough for them to have a half folding or a soft folding that they can support themselves with something. So it's worth it to get the injection. Even for a normal person who not treating a lot of that thing or not worth it, they didn't have a, but it millisecond enough for you to give yourself some support. So I would do it. I would use it.
And also, do you have the specific muscles or the areas to target mainly for?
I don't understand.
Okay, so sorry. For in case for you would like to inject the Botulinum for a target of the apraxia opening, do you have the specific muscle to target that is the same or different between compared to the usual muscle that we inject for the blepharospasms or not?
You just inject the muscle for the blepharospasm, but you in a very small amount. Now tell me, where do you inject for the blepharospasm in the eye? You guys? This is not in the book. That's why I talk now on the phone. I couldn't overcome the people when I want to describe it. Where do you inject for blepharospasm? Who want to raise the hand? You? Yeah, the lady. Yes. Tell me the point you injected.
Oh, for blepharospasm, right? So I usually inject with the orbicularis oculi as a tarsal area, like for 1, 2, 3, 4, 5, around 5.
5?
Right.
Okay.
And avoid.
And so one here,
right.
then here, and
Right.
here. Okay. That's the way I would do too for my mother-in-law. Okay. You know the joke of a mother-in-law? Okay. But for my mother, I do differently. Okay. You want to know how I do for my mother? Here. I would do here a tiny little bit. Here, tiny little bit. here tiny little bit, and here tiny. Or I avoid here or at all. Why? If we look at all the patients who have blepharospasm, the other inject, we have the redness. Why? When you inject the blepharospasm, the eye have to flow this way, in. So you inject here, you weak enough, they don't show, they have the redness. Okay? You inject here. So the most of the clothing is blepharospasm by the upper lid. The lower lid, you against gravity, you get too much problem. Okay? When you inject them, they open out. So in the upper lid, you inject here, then you inject here in the middle. Everyone will tell you that inject in the middle, that have the levatos front of it. The patient have eye too. No, they don't. Why? Between the oculi and the levatophantobe, if you look in the anatomy, look carefully, there are small membrane that separate the two muscles. So if you inject that and inject it here, but at the eyelash level and subcutaneously, you have to hold your hand like that, okay? And just barely through the skin and a drop there, half a drop there, the patient eye opening, wonderful. And I don't do drop because their membrane is separated. Check back an anatomy book. Check it. Okay?
Thank you so much, professors. And the dose, how many doses you recommend to injections in the elevator palpebral when compared to the oculis or the medials and the laterals and elevator palpebral area? How can you calculate for the dose? Do you use the same dose? How do you calculate for the dose of the toxins?
To be honest with you, how much you have here, I don't even care. Okay? The one that makes the difference is the one here. Okay? Someone want to be the volunteer? I show. Come in. Needle. I will check here, right? Here, at this point, and the other at here. Okay? Just above, and you go there, just underneath the skin, and you deposit. Just give it one try, okay? And if it works, invite me back. If it doesn't work, I pay my ticket. What? Surely, a sensitive. No. Surely a sensitive, but use a small needle. To be honest, I have never have a patient complain about the pain when I keep their eye open for 3 months. Okay? And actually, I had that one guy who fly all the way from Miami because the doctor in Miami didn't want to do it. He fly to me, and each time he come and just want to give me $1,000 just for me to do it. But check in anatomy what I said. I don't even bother. No. I use about 20 units for blepharospasm. Okay? 20 units for blepharospasm. That's about. The dose that doesn't make the difference. The one that makes the difference is where you put it. For example, the one here, the one who gets the most, because on the pretectal, the frontal, and prepalpebral muscle. The one here in the most sensitive one to the toxin, read in the book. You know, you have to understand it like an arrow. String in the arrow, okay? The string, you have on the bow, okay? The bow, We have the string here, 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 here. We cut the string inside. The bow is held by the string here. It doesn't make any difference. We cut the string from here outside. They open our eye. That's the logic behind. Just try it. I normally don't show it in the United States because I have competition. Here I don't. It's far away. I'm kidding. The thing I show you is not in, but that is the one. You try to make it impressive and you see it. Even one will look like your face, so beautiful. So people can see when I say that.
Okay.
Okay.
Can you continue your presentation?
Yeah, but remember the line here. Can you pull it up? No, this one. You cannot put this picture up. Yeah. You see that? That creates the line here. The double chin and triple chin. Thank you. So, should I do the clothing or how to? No, I think that's better. Leave at the high point. This the picture from Putin, the clothing. That we will never forget. You agree? Anything about you want to ask about? Ask me. I will tell you what is not in any book. So we have today. We talk about today about plasticity. We talk today about dystonia, and I think most of them is known, and a few new feature about the position of the head, that you see analyzed by Dr. Thai, and actually the man who described it, the picture was from me, and but that give a new judge for analyze it. Actually, when we submit the paper for that to the Green Journal, it was rejected. Okay, because they object to the definition of the toxic caput. And I know who the one who rejected, Hubert Fernandez, was the one of the reviewer who objected to the term caput. But we don't have a term afterward. But that something help us to analyze further. What I would do in this case is I go to the deep muscle in the upper head, especially if you have the ultrasound. But without ultrasound, it's okay too. You can do it.